Welcome back and many thanks for staying with us on the #1 breakfast show in the country, Morning at NTV. The coronavirus pandemic is still pretty much rearing its very ugly head. We do know that 71,543 people are grappling with COVID-19 in this jurisdiction of ours. And we also do have a 42-day lockdown. Total lockdown that is in its third day. Patients with chronic conditions and other ailments like COVID-19 are battling for access to health care, and they are wondering how they get that essential medicine and are looking left, right and center. Now, to expand more on this conversation, I'm now joined by Chris Lucolio, the digital country lead at the United Nations Capital Development Fund. We also do have Elena. Yes, Elena Kembabazi. She is a program manager Right to Health at the Initiative for Socio and Economic Rights. I'm also seeing Dr. Sesanga Arthur. He is the Director of Medical Services at the International Medical Center. We also joined from Democratic Republic of Congo by Dr. Ofi Tamba, a public practitioner in the DRC. Now, gentlemen and lady, welcome to Morning at NTV.
Thank you, Romeo. It's good to be here.
Indeed, quite amazing. Let's kick off with Dr. Arthur Sesanga, the Director of Medical Services at the IMC. Dr. Arthur Sesanga, you run a chain of clinics that are, spread all over the country. And I do know that your patients are clamoring for your services. How are you reaching them?
Morning, Collins.
Romeo.
At international medical centers, we want to offer digital health solutions to the clients who are stuck, especially in the lockdown.
Indeed.
We are currently attempting to, as much as possible, get to each and everyone who needs health care. The international medical centers are spread throughout the country, and we started the digital health solutions to access drugs to our clients through the telehealth solutions that we developed. So with the guidance of IT systems and also partnership with MTN, we've made it available to everyone wherever they are. So wherever someone is, they can call into the IMCs and get their drugs delivered. But also we have, because our medical riders are clinically trained, okay? So they can be able to get to each individual person, take your blood pressure. If you need a blood sugar to be done, if you're diabetic, that can be done. If you're hypertensive, it has a blood, a sphygmomanometer, or what is called a blood pressure machine. So your blood pressure will be taken. So the medical rider will be able to give you ample service. If a doctor is needed on the other side, then the doctor will be called and then a further discussion will be held. Now in the current lockdown, and especially with COVID, the pandemic, we also, that medical rider is properly trained to be able to take off a sample. They've got all the gadgets they wear and they take all the precautions that is necessary. So they can equally be able to take off your sample from your home, from your office, from wherever you are, and you get your results online. So we've come, the digital health solutions have helped us so that we can do treatment from the confines of your home, confines of your office, where it's possible, and everywhere that you are. Now we access even remote places because, as I said, we are spread throughout the country, all around, in Arua, Gulu, Soroti, and Mbale, even in Barara. So we can access the remote areas and the doctor can get to you and you can get first-class services through the digital health. Collins?
Well, thank you very much, Dr. Arthur Sesanga. He is the Director of Medical Services at the International Medical Center, and it's Romeo Sir. Let's also bring in Alana Kembabazi. She is the Program Manager Right to Health at the Initiative for Socio and Economic Rights. Alana Kembabazi, you and I know very well that this second lockdown appears to be unplanned and very haphazard in that regard. So I would like to know, because you lead and research into health rights at the Initiative for Social and Economic Rights. So talk to us about the impact of the first lockdown. How bad was it, Elena, as we speak? And what do we have in store or waiting for us in the second lockdown?
Yeah, it's unfortunate that we do have to be in a second lockdown because of the cases and deaths. So on the one hand, I understand government there, but the impact of these lockdowns is devastating, not just on incomes, but a lot of time on continuity of healthcare. the last lockdown, we had patients, for example, cancer patients, just failing to get healthcare for months, missing treatments. We had HIV patients missing refills, and others who need regular refills. We had pregnant women that died trying to get to a facility. And so there's a lot of importance in ensuring that there's continuity of healthcare, because your disease does not pause because there's a lockdown. You still get the medical emergencies, you still need the access to drugs. And I think that for me stems from the ways in which we have failed to make our health system deliver the way it should. Our policies are clear about having to have a health facility within 5 kilometers, but somehow we find it very okay to have entire districts that don't have district hospitals, sub-counties that do not have health centers. But also we've decided we are going to, for example, centralize the treatment of cancer care for those who have to rely on government facilities only, particularly, such that you only have to come to the Uganda Cancer Institute. Remember last year, the Cancer Institute was stuck with people. Some of them had come here, then they had to feed them because they could not go back, and those who were there could not come across. And in this lockdown, because remember that as much as we're now on like day 2 or 42, we had to do a reset. But even in the earlier, like the last 2 weeks, districts have been closed. And so earlier on last week, we're asking the president, how are people moving to get healthcare, to get medicines to their loved ones? We saw people reaching out to digital solutions, but those are people who have means. Who would say, okay, I'll call Rocket Health, or I'll call this pharmacy, or if I am in Kampala, I can call IHK right now, whatever. But again, you're dealing with only a particular class of people. So given the right to health, it's a health, I keep saying, is a right. And so it shouldn't be a privilege that only a few have. I think it's very important that we think about continuity of care. Now, the government this year has said, if you have a medical, you can either go to the medical facility and get a referral or get an LC1 letter. Some people argue that is still, it's a bit better than last year, because last year you had to get an RDC. Some of us didn't even know RDC, they didn't ask for money. But it's still not as seamless. And again, even if you go to all these things, you have to find a way to transport yourself. And so we need to be thinking, how do we bring health services closer to people? I don't know that I would at this point say, for example, the government should be able to have sort of the digital, sort of the riders that go out. Although I guess if you look us down, maybe you should have had a plan, because you had years to build facilities closer to us and you did not. So if you're going to look us down, you should be exploring all kinds of options to get healthcare closer. But I think the fact that when IHK and others talk about these options, my first thought is the people have met, the women just trying to get their cancer or HIV treatment, and how they are left out of this system. So for me, it's just a real call to have improved access to healthcare, and for government to invest in making sure government facilities do have them, because again, they serve the poor and the majority of us, because a lot of us just won't be able to afford some of these options. But also just to add that with digital health, the other bit about it that I think is relevant, the discussion happening right now, is just being able to have data, right? Where are people? And how do you interact with them? And I think that's super important right now. So it's something that the government can emulate from the digital health sphere, just being able to figure out, this is where someone is. Because right now you only know people who come to your health facilities. So sometimes you're not very sure what the impact of certain things will be. But now if you have data, particularly from private providers, if they share that data, which they should, about where the people are, it would be useful for planning purposes in the future.
The onset of the first pandemic and the lockdown that was in March of 2020, we did see so many pregnant mothers die on their way to the hospitals at the hands of police officers or security members who did not or who couldn't prioritize that maybe person X needs some kind of help, even though they do not have clearance from the LC1 chairperson. So even the same, last week I was moving through the curfew hours with some police officers in Nasa, Uganda, trying to work with them and ascertain whether or not our people were adhering to the SOPs. Then I met a mother. She was actually pregnant, and she was telling me how police officers had roughed her up, yet she was trying to access a medical center within that jurisdiction. Do you have such a situation during this new 42-day total lockdown where people in her situation are actually going to be succumbing over the implementation of the SOPs?
Absolutely. And even I think some of these providers, like say Arthur was, sending some of his health workers, I think in the beginning, it was not even clear if they could ride, right? This year it's a bit better, but I think last year was really haphazard because if you're not supposed to be having a bike and some, it was just all very unclear. We've also received reports that even this year that, for example, health workers are struggling to get to health facilities because initially they say move with your ID, so forth. Then at some point there's a health worker I think who was on a border and they said no, the health worker can move. You're not supposed to carry her. And she's like, how do I get there? So people have been sending in reports of health workers that walked like 2 or whatever hours to get the facility. They're exhausted and they have to figure out how to get home. They're thinking, what is in it for me to sacrifice myself to this extent? But I think for me, a more sustainable solution generally is to bring these health services closer to the people.
Indeed,
make sure the health facilities are built closer, and then you can have the conversation of can people walk, otherwise we cannot continue like this. You can't, people otherwise are going to have to beg, Arthur, please, can you get me, I don't even know how, if I'm a cancer patient right now, Arthur, in Amdat, how do you help me? Tell me.
Great insights by Elena Kembabasi. Great insights by Elena Kembabasi. Thank you very much. She is a program manager, Right to Health, at the Initiative for Socio and Economic Rights. I also have Dr. Arthur Sesanga. He is the Director of Medical Services at the IMC. We also do have Dr. Ofi Tamba. He is a public health practitioner from the DRC. And also Chris Lukolio, the Digital Country Lead at the United Nations Capital Development Fund. But before I go to you, Chris, let's get a picture of what is happening within the DRC. Dr. Ofi Tamba, talk to us and paint for us a picture of how the COVID-19 pandemic is wreaking havoc within the DRC. Good morning, sir. And of course, we are talking about DRC that has a total of 37,808 cases of COVID-19. We wanted to have the public health practitioner, Dr. Ofi, paint for us a picture of what is happening in terms of COVID-19. There you are. Very good morning, sir. Acquaint us.
Good morning. Thank you so much for inviting me to this great panel to talk about the situation of COVID in my country, the Democratic Republic of Congo. Currently, we are, I would say, for a couple of weeks now, we are in the third wave of the pandemic. The government has made some decision to make sure that we can deal with this third wave. We have around now 400 cases per day, and for the entire country, and Kinshasa is still the Kinshasa, which is the capital city of the Democratic Republic of Congo, is still the epicenter of that this third wave. But we are not in lockdown. We are not in lockdown. There are some measure like people have to wear masks in public. There are gatherings of people of more than 20 people are not allowed. Churches are still open, but restaurants, bars, and nightclubs are closed now. And school and university are still open. So we are not in lockdown, but yeah, the situation is a bit worse than what it was, I would say, a month ago. Yeah.
What about access to medicine and other health services for the many people within the DRC? Are citizens still flocking these health centers physically, or is there a strategy to actually embark on telehealth or telemedicine?
So far, they can still get access physically to the health facilities since we are not in lockdown, as I said. So people can still see the doctors and they can get the medication. And for the patient who need refill, they can still go and take the medication as usual. But yeah, the capacity in hospital is very limited now. So yeah, because there are some measures that have been put in place. So the situation is not as, I would say, as normal, but yes, people can still meet their doctors. They can still access to the pharmacist and so on. They can move, they can go to work. The capacity, for example, I would say the number of people who can go to work has been reduced to a maximum of 50% for most of the companies, even for in governments, in our government settings. But life is still like a little bit as normal, I would say. So people can still get access to the health facility.
Indeed.
And I would say, yeah.
Dr. Afitamba, this is what my people in Uganda are grappling to understand. You're in a third wave and you're only having 37,808 cases of COVID-19. We are in a second wave and we are grappling with 71,543 cases of COVID-19. We are trying to make those additions to understand what is happening within the DRC. It means in the third wave, you could be having more cases than what meets the eye, because your president, Felix Tshisekedi, he came in last month and he said we are overwhelmed by COVID-19. So is that a commitment that we are going to see a rigorous campaign on the ground from the government trying to curtail the COVID-19 pandemic? But largely, that's not what we are seeing. Life is largely back to normal.
Yes, I would say the situation you're representing is correct. If I got you, I got you right. We are still in the we are in the third wave. But if I should think as a government, I think there are some level of measure that you can put in place. And for the DRC currently, if they decide to lock down, it's going to be a bit a disaster in this situation now, because the country is not prepared to, for example, to deliver digital care and like to organize the I would say our health system is still paper-based. The system is paper-based. The infrastructure are not there. So I think that it's going to hurt more if the government decide now to lock people down and decide not to let people have access to their doctor than if we are in this situation. That's why I think that the government is a bit trying to manage with those measures they have taken, because our country is not prepared to be locked down. It's a reality. Maybe we will get there if the situation gets worse and worse. But honestly, the country is not prepared. And yes, we are still seeing what the government is going to do. But no, I would say it's going to hurt more the people if they decide to do the lockdown, to lock the country down now.
Wait, I have a quick question.
Before I let you go, Fitamba.
Just to ask him, because he says something very critical. He says that
I'm gonna let you expand more on. I'm going to let you expand more on that, but I wanted him to paint for us a picture of what is happening within the DRC, especially with the people of DRC who are escaping the volcano, Nyiragongo volcano. We do know that exacerbated the number of people who are on the streets. Yes, we'd like to know, don't you think that led to an increase in COVID-19 cases, Dr. Ofi? The fact that people are running away from Nyiragongo volcano?
Yeah, that's a possibility. They are monitoring the situation over there. That's a possibility that the number of cases can increase over there. I don't know if I got your question when, but that's a possibility. And they have taken some measures over there specifically for that region as well. But yeah, it's obvious that people are exposed to be contaminated or infected to COVID-19. Thankfully, Goma has not many cases as in Kinshasa. But yeah, there is that risk, and it is monitored now. The government is monitoring that situation very closely. But there is that thing that the number of cases over there can increase quickly.
Public health practitioner from the DRC. Let's also bring in the digital country lead at the United Nations Capital Development Fund. That is Mr. Chris Lukolio. Mr. Chris Lukolio, you have supported Uganda's digital transformation, courtesy of the United Nations Capital Development Fund, for a while now. Would like to know, would you say that we are in a place or position where digital technologies can support end-to-end health service delivery?
Thank you so much for having me. Indeed, the UN Capital Development Fund is implementing a program in Uganda focused on leaving no one behind in the digital era. And I would say that I think that even though this is a time of tragedy, it's a pretty trying time, I also think that it's also a time to see opportunity. I think that Alana mentioned that there are lots of policies in place. I think that the government has been, if you look at other governments across the globe, this has been one of the governments that has really embraced digital transformation. If you look at the National Development Plan, it's a very central piece. And so I think that there are opportunities. Luckily, in the healthcare sector here, if you look at rural areas, and we work very much in rural areas where there are those communities that are in danger of being left behind in this digital era, you'll find that healthcare is primarily delivered through community health workers. In Uganda, we call them village health teams. And so even though a health center might be far, there are community members who are conducting assessments door to door, whether it's prenatal, postnatal care, HIV, malaria. And so there is an opportunity. And I think that if we talk about, is Uganda ready to harness technology to deliver healthcare? I think it is, through these village health teams. And we are working with several partners like BRAC, you have several people like livelihoods, and the Ministry of Health is very strong in leveraging these village health teams and now empowering them with technology. So somebody comes to a doorstep with a mobile device and is able to ask, is there a pregnant woman here? When was her last checkup? What medication is she on? And can make those referrals. And I think that that's an opportunity. And so I think that what we've seen as this pandemic has raged on is a greater appreciation for the role that technology can play in the delivery of healthcare. And now with our health system having those community health workers as primary healthcare providers in these rural areas, I think is a big opportunity. So as we build, I should mention that UNCDF in implementing this program focuses on working with policymakers to ensure that policies in place are conducive for people to take on and use digital technologies for their healthcare and well-being. But also we work to foster inclusive innovation, that innovations that are put in place are considerate of those rural communities that are otherwise in danger of being left behind. We also try to build digital literacy. And this is where, again, I see an opportunity that, yes, as we take on bigger projects, because this is a huge pandemic, the entire globe has been affected. There's so much that is unknown. So indeed, there will be challenges in delivery. But you have these community health workers who, in many cases, now all of us have access to phones. Many of us have access to phones, even simple phones, that as we build digital literacy, as we try to improve the ability of different community members to use these devices, there's opportunity to share information, to have assessments at these doorsteps, to deliver information, and the SOPs can be better adhered to as we leverage technology. So to answer your question, I believe we are uniquely positioned, and I think that we should harness this opportunity. Frankly, there was a time when technology in healthcare and education was seen as this, nice to have, a good thing for Western countries. And now we see it as a necessity. And indeed, technology is not an end in and of itself, it's a means to an end. And I believe that we have the window here as we try to survive this pandemic to harness technology to make sure that no Ugandan is left behind. Thank you.
Mr. Chris Lukolio is the digital country lead at the United Nations Capital Development Fund. Thank you very much, sir, for that great insight. Let's also bring in Dr. Arthur Sesanga, the Director of Medical Services at the International Medical Center. Arthur, how have you overcome questions around credibility and trust issues that come with technology? As a person, how do I convince myself, or how can you convince me that a voice behind the other side that I can't see is telling the truth, Arthur? How do you convince me that the voice on the other side is telling me the truth, that I can't look in the eye?
Romy, I didn't get you very well.
We are talking about questions that might come around on credibility when it comes to technology. How do you convince a citizen that the voice that they can't see on the other side of the phone is telling them the truth?
Okay, that they can't see the person.
Go ahead, Arthur.
Arthur, your sound has gone off.
All right, we are talking about adapting digital technologies to the new health care demands. I have Elena Kembabazi, the Program Manager, Right to Health at the Initiative for Social and Economic Rights. We also have Dr. Arthur Sesanga, the Director of Medical Services at the IMC, also Chris Lucolio, the Digital Country Lead at the United Nations Capital Development Fund, and also from the DRC, Dr. Ofi Tamba, who is also joining us in that regard. Let me also bring in another of our guests. That is Dr. Ofi Tamba. What does Dr. Ofi Tamba, did we learn anything from the COVID-19, from the fight against Ebola, when it comes to fighting this pandemic?
Can you repeat the question, please?
Did we learn anything from the fight against Ebola as we are using these lessons to fight this COVID-19 pandemic?
Yes, there are some lessons that we have learned from Ebola, especially about the communication, because there was a similar issue communication-wise when they are trying to implement vaccination activities against Ebola. I think we have learned those lessons, but we are not using them well so far. So that's what I can say. It's the first thing that we learned. The second thing we learned from the Ebola outbreak, or the several Ebola outbreaks we have already have in our country. I think those outbreaks has revealed some of the weaknesses of our health system that we should be working on. And I would say the third thing or third lesson we have learned from the Ebola outbreaks we have had in Congo is that I would say that we should be prepared. Like we should have like emergency preparedness plans for the country. And also, yeah, that's pretty much the three lessons I can say from the top of my head now. But yeah, I think the communication issue is the biggest one. We have learned from Ebola, but we have not used that lesson or used the conclusion, what we have learned from the miscommunication during the Ebola outbreak, the two last outbreaks in Congo. And we should work a little bit more on that for the current pandemic.
We did see people embracing Ebola vaccines, but during this COVID-19 fight, people are hesitant to embrace these COVID-19 vaccines. There could be the difference between the Ebola fight and this COVID-19 pandemic. Elena Kembabazi, let's talk about the fact that this conversation comes amidst service shortages to the extent that private citizens are installing oxygen tanks within their homes to support relatives who are ailing with COVID-19 disease. How did we come to this situation, Elena Kembabazi? How bad is it? And do you think as an activist we slept on the job? Elena.
Yes, and I think, Romeo, what you also raised is a critical issue here, where, and it's a question I asked earlier to the DRC, that it seems like maybe their health systems, I don't know, from what Tamba was saying, it seems like their health systems are still not overwhelmed. In Uganda, they are, and that's a shame because we had 1 year to get this together, and we should have prepared for this. We got the resources actually and the time. So there was a real faith on that end. But now that we are also here, we are seeing that, again, there's a whole lot of just profiteering, price gouging, forgetting we're in a pandemic, which we are. And so seeing that, the cost of oxygen and the basics have been so astronomical, even in private facilities that are not necessarily, that are sometimes going to get, for example, oxygen for free from roofings, right? It shows, again, a lack of regulation of actors in this space. So even as we think about as we think about digital technology and the potential it does have for the private sector, for the Ugandans, right? There has to be a regulation of the actors in this space, including the private sector. I think it can be a valuable source of data so that you sort of know who is where in the community. So if you know that, for example, in Arua there's an oxygen shortage, you have a sense of how many maybe active users or so forth harnessing the technology. But I think we do have to again make sure that any actor in this space is not treating this as just a normal business. Healthcare is also a human right, and access to it is. And with digital technology, issues around privacy of the patient's data are also very, very important in how you handle that. And so I think that there's a lot that we can reflect on from this moment. one around government preparedness, around not just pandemics, just the way in which we treat our health system. Can we get it together and finally fund and fix the public health system? That would mean including having money and making it more accessible. It would mean that we have data and are using digital tools to make sure we have data on where our patients are. And also regulating every actor in the space. They can complement government, but it cannot be business as usual. And as the other thing that I would say, the question I guess I've said for everyone else is, you know, as we talk about those things, for example, Chris was talking about, you know, like a BRAC project, I think, that has these mobile tools and so forth for living goods. We need to make sure that these things are part of the public health system. They cannot just be projects that come and go. If you're really trying to make sure that we are strengthening our health systems, they have to be part of the public health system. The lessons learned must be there. And at some point, you take the training wheels off. Government should learn to be able to say, okay, we have integrated this and we go. Such that we're not dependent entirely on well, you know, people who are partners who are trying to do good, either whether they're not for profit or maybe in private sector. We don't want to have a system where we build our entire foundation on it. These other actors can come in and complement. But what Ebola showed us was we must have the government really running the show when it comes to healthcare and getting serious about it, being able to centralize its response in some instances, being able to plan for its people, being able to make sure, okay, we have enough beds, we have enough oxygen. If there's a surge here, we know that there are a lot more pregnant people here. So therefore, if we do institute lockdowns, we already have the data and can easily say these people here are exempt. So that planning will require, yes, digital tools, but above all, it requires political commitment. And that for me is very concerning because right now, I don't know that I see it yet sufficiently. And when it comes to regulation, I had Dr. Atwine yesterday speak and say, oh, the law does not allow us to. Actually, our law does. And our law is very clear that protecting the right to life is fundamental in this country, right from the Constitution. It also ensures access to medicines and healthcare. So we have to be able to think through how other actors and other technologies don't violate as well.
All right, Alana. With the number of COVID-19 cases skyrocketing to 71,543, this conversation couldn't have come at the right time. Adapting technologies to the healthcare demands that we are grappling with right now with the onset of the second total lockdown, 42-day lockdown, which is in its third day. I have Elena Kembabazi, Chris Lukolio. I also have Dr. Arthur Sesanga and also Dr. Ofi Tamba, with whom I shall expand more on this conversation shortly after these messages. Keep it here on Morning at NTV. You might be checked anytime soon. So please take advantage of the item product. They are so beautiful. They'll enhance that relationship between you and that fine lady. I'm really talking the truth. Right here, I do have Arthur Sesanga. Dr. Arthur Sesanga is the Director of Medical Services at the International Medical Center. He's not alone. We also do have Alana Kembabazi. She is the Program Manager, Right to Health at the Initiative for Socio and Economic Rights. We also have someone from the Democratic Republic of Congo, a public health practitioner, and that's none other than Dr. Ofi Tamba. And last but not least, we have Dr. Chris Lukolio. He is the Digital Country Lead at the United Nations Capital Development Fund. Three gentlemen and that lady still are with me via Zoom, and many thanks for staying with us right here on Morning at NTV. Let me come to you, Dr. Arthur Sesanga. Let's talk about issues of credibility and trust issues when it comes to using technology. As a citizen of this country, how do you convince me that I could trust a voice that I'm not seeing? Expand more on that. Issues of credibility.
Thank you, Romeo. And I hope I'm clearer now.
Yes, you are.
Technology, indeed, it's a big challenge, especially for clientele who might not have used, for example, Zoom links or even a video on WhatsApp. It's a tough one, but the telemedicine initiation that we have so far has what we call the tele-appropriate and inappropriate conditions. There are things you'll not be able to handle on the telehealth platform, And so there's what we call a triage. When you call in our free number, you'll be able to be triaged and see whether you're appropriate for this session. And then the doctor will go ahead, then it will be forwarded to the doctor, and then they will deal with your condition if it's found appropriate. Now, it's a bit difficult, it's a bit novel, and some people may not appreciate it that much. But interestingly, for not only in COVID, but especially COVID clients that we've managed using the telehealth medicine, it's been quite a good experience, and they've had very good outcomes even on that telehealth platform. Now, the other thing to note, even for communities where it's remote, like Alana alluded to, I don't have a smartphone, I can't, and that's where, like Chris shared, we need the public-private partnerships so that we harness this product, because a medical rider could get to this locality, and then they'll be able to, because our medical rider, for example, has a smartphone, so they will be able to link in, and then on the other side is the doctor, and they will be able, the person will be able to see the actual clinicians who's working on them. They can share a few things, and then the medical rider, as I said, is a medically trained personnel. We continue with the things that need physically to be done, like taking the blood pressure, doing your oxygen saturation or the pulse oximeter, and anything else, or taking your blood sugar. And then the doctor on the other side will recommend what medication you can be placed on, or adjusting your doses. It's the same thing even with the COVID. If the medical rider has gone and taken off a sample, and if we're doing the rapid test, then we can get the readings within 15 minutes. So someone can quickly decide on what will be taken. And remember, he goes with a pack. We have a home care pack, so that can be provided immediately to the person in need. So all that is something, it's still new. Some people have not gotten used to it, but we are gaining mileage. And if we do that public-private partnership, Alana, it should be, I think this is an opportunity for us to partner with government. And since we already know how it's run, we've already tested it, we've gone out in the countryside. I've treated people as far as Busia on that telehealth project, and they've had very good outcomes. So someone goes, picks their sample, brings it back to the lab, and it can be run. So I think in times like this, this is the opportunity for us to partner. Remember, we're only partners with government. We do not, all the patients we treat are for the government of Uganda. And so we're just helping to ease the management of healthcare in the country. So if only we can strengthen and harness these partnerships, then I see a very great stride in how we can achieve this. So even those cancer patients, Alana, that you're worried about should be reached, should be managed, even when lockdown is biting so hard for everyone. So for me, it's a great opportunity for all of us to work together. We've tried it, we've seen it, but of course it's limited by the fact that we've not reached out to everyone. But when we get into the government too, I think we'll reach the whole country. It's an opportunity for us. Thank you, Romeo.
Mr. Sesanga, do you envisage a situation, or do you see any business hits in terms of a drop in business as we grapple with this 42-day lockdown?
They drop in business, you mean?
Yes.
Okay. In honesty, yes, of course, because of the lockdown, access to healthcare facilities drops. And as such, people resort to self-medication, treating themselves at home. And you've seen everything that's going on social media, especially not only but for COVID. So as such, people are not seeking medical care. Again, as a healthcare practitioner, I've been in practice, I've practiced both in government and the private. My passion is to see everyone get care. Our passion is not necessarily only to drive business. I have to admit that we've got to have funds to pay the workers. That one I can't deny. But again, we want to reach out to everyone. Currently, we offer HIV treatment on the free package of government. So we purely give out the drugs without costing it to anyone. So we still feel that in as much as business will drop, the people need the care. We need a healthy population. because that's what the whole country needs for the economy to thrive. So in as much as business might drop in health-wise, we can still use this opportunity to reach out to everyone and provide for them. And I wouldn't shy away from partnering with government. And if they can, for example, provide that fuel for my bike and maybe a bit of facilitation for the biker, those free services can be accessed even to the government entities. So I think I'm not worried in terms of thinking business will drop. No. Most importantly, we need a healthy population before we can think about
Arthur Sensang, the Director of Medical Services at the International Medical Center. Let's also bring in the digital country lead at the United Nations Capital Development Fund, Mr. Chris Lukolio. As highlighted by Mr. Sensang, he says that people are not going to health centers physically, so our best option is adapting technologies to meet this demand. But how best can we ensure that we increase the capacity of our digital health startups to meet that level of brick and mortar health services?
Thank you so much. I hope I caught your question well.
Indeed.
You're asking how to increase the capacity of our health centers to adopt technology, is that right?
Digital health startups to meet the capacity of the brick and mortar health centers.
Okay. No, thanks so much for your question. Indeed, it's a very good point that many times when you look at a healthcare system, you wonder how will it survive if there's no support from the outside. And I think that's a very important point because at UNCDF and several other UN agencies, we are actually operating a system called a market systems development approach. We are not, the idea here is to pilot and scale innovations that are actually being undertaken by people within the market, that these individuals should be able to deliver these solutions even when, development partners are not part of the equation. And so indeed, we do see that there are several startups that are eager to extend solutions. I mean, if I can, somebody did mention Rocket Health. These are providers of telemedicine services. We also do see quite a lot of other startups that are looking at payment services to allow patients to pay for services even when they might not have access to cash. So the idea is that if we're going to foster inclusive innovation, if we're going to make it possible for these startups to serve a more distanced population, I think that one, there has to be an enabling policy environment. And I should say, indeed, at least the government of Uganda does a good job in putting in place policies. We can have a debate about implementation of those policies, but the policies are in place. And we do see lots of innovation parks. We do see lots of subsidies on technology equipment. So the idea is to create an enabling environment that innovators can actually create these solutions and benefit from them. The second is that we have worked closely with big players in the digital space. These are the people who provide the infrastructure on which these solutions might ride. And you might know of something called an API. This allows one program to talk to another. There are several institutions, mobile network operators, banks and so on, who are opening up their APIs. That if I, as an innovator, have a good idea, I might be able to access certain APIs for free that allow me to extend services to rural communities. And so these are other initiatives that are allowing, that would allow startups to better innovate for rural communities. Last but not least, this concept of open data system that, allowing one database to talk to another. Look at, in many cases, one example is the ID system, right? That if every time I have to access services, I need to show an ID, especially for services that might be free, maybe provided by government, are there ways to leverage open data systems whereby the know your customer protocols, KYC protocols that are developed by, say, a mobile network operator when you access your SIM card, can those be now used by an innovator like Rocket Health, like others? And Dr. Sesanga was talking about, they provide HIV treatment that is free. If I need to show an ID, is there a way to make that I don't need to show a physical ID every time, that there's a digital ID that can be captured and my services can be extended to me? And so these are some areas where we're working, but again, in partnership with local counterparts. This is local ownership and local capability, because again, as I mentioned earlier, that there is an increased awareness and an increased appreciation for the role that technology can play in delivery of healthcare. And to your question, how do we make sure that startups are more able? These are some of the steps. Indeed, an enabling policy and regulatory environment, working with private sector to open up some of the access to those to that infrastructure that I talked about, but also ensuring that I think we have also been talking about increased digital literacy. I think you raised a very good point about how does somebody know that the person on the other end is legitimate? And so increasing the awareness of our public to know that, all right, these are the questions I ask. This is how I verify the information I receive. This is how I might verify the identity of the doctor on the other end. And so those are some aspects that would make the startups in our ecosystem better able to meet that demand, to meet that gap for healthcare within this pandemic and indeed beyond. Thank you so much.
Thank you very much, Chris Lukolio. He is the Digital Country Lead at the United Nations Capital Development Fund. Let me also bring in Elena Kembabasi. She is the Program Manager, Right to Health at the Initiative for Socio and Economic Rights. Elena, during the onset of this pandemic, FSDU Uganda conducted a study that indicated that 1.8 million traders, these are mostly women, might not go to pre-pandemic economic activity levels that we saw before the onset, that is in 2019. Now, as we grapple with this 42-day lockdown that is in its third day, do you envisage a situation whereby more women and other vulnerable groups fall more into poverty? We are talking about agriculture that largely stayed open in 2020. Now we're talking about an inter-travel ban and so forth. Do you think the women who are largely within agriculture are going to be affected the most as we move forward? Alana Kembabasi,
yes,
the impact of this pandemic.
Yes. I want to, first of all, one of the things you've mentioned is very important. The biting economic effect of this pandemic on livelihoods. And that must be kept in mind as we talk about what government should be doing now and who can afford it. As I talked about, for Alana, don't really use your service for affordability reasons. And I'm a privileged person. I am quite privileged. And so I hear some of this and I say to myself, is that where government should be putting its money? Because more than ever, we used to think that public health systems were just going to be for the poor. But more than ever, we are all going to have to, because what COVID has shown is today you may have a job posing with your insurance, you can call these guys, you can go there, and tomorrow you might not, in a blink of an eye. And so we must make sure that we have strong foundations and basics. We were just talking on the call during the break, and Tamba was telling us how in the DRC, you can get a rapid test for free. In 10 minutes, you have your results. That is why their COVID response probably hasn't reached as crazy as ours. But right now, even in these digital tools they're talking about, how much do you charge for us to get an RDT? And you're going to talk about, government, if it puts some money in a public-private partnership, it gives you fuel, all of that. This is a reality. We have had public-private partnerships in this country with not-for-profit entities who, let us look at the end users. We still find these services unaffordable. We still find that women, pregnant women who go to these facilities to give birth because government has invested there, saying the private sector will deliver, have been detained. Just in December, Isa had to run and rescue a 15-year-old girl that had been detained. She went there, there was no public alternative. She went to this PNFP, PPP, and there she was detained until we came in and intervened. So as we talk about where government should put its money, I want us to remember the people who we serve and where they are in terms of livelihoods, in terms of the remoteness of where they are. I think government should use its existing systems. I like the idea that you have a community health worker, for example. They know their community, they know where these things are. They go there and they connect. But also government should be stepping up, making sure that these facilities are equipped. Let me tell you, you can only do so much with telemedicine. Is it important? Yes. But now say it's a pregnant mother. What you need, the telemedicine will come in as an intermediate intervention to know, do you really need to, are you probably having labor right now, or is it a contract? Or like, do you need to get the hospital right now to have that conversation? or if it's a cancer patient, you still need to be able to examine. And I know this from having cancer, of taking cancer patients, where yes, you may have pain in your bone. I'm going to have to see. I think any doctor actually worth their back.
Lena Kembabazi, thank you very much for that humble submission. Let me also bring in Dr. Ofi Tamba from the DRC. Dr. Ofi, has the DRC adopted any technologies to keep delivering healthcare services during this COVID-19 pandemic? Dr. Ofi.
Sorry?
Has the DRC adopted any technologies to keep on delivering healthcare services during this pandemic?
Yes, I would say yes, but not the government. Like some private hospitals and organizations have implemented digital health services, but at the government level, no. As I said, the things are still open, so they did not. They have not started to implement such initiative. But yeah, on the private healthcare sector, yes, they are doing that already, and unfortunately, it's only for people who can afford to pay for those services, because I think that there are some steps that you have to follow to reach to that level, and those private hospitals and private organizations have already made those steps to implement such initiative. But for our government, we have not yet implemented digital healthcare so far.
Dr. Arthur Sesanga, the Director of Medical Services at the IMC. Dr. Arthur, we also do know that the 12% tax on data is taking center stage or being activated on July 1st during the onset of the financial year 2021-2022. Don't you think that tax on the internet is going to have an effect on telehealth, on telemedicine, now that we are telling people to clamor for digital health services? Let's be honest.
Tough one, indeed, Romeo, and indeed it might affect the usage of the telehealth, or even make it more expensive. It's difficult to tell how the uptake will be, but those are also discussions that someone can have and see how that can be enhanced. Again, I will not shy away from saying the relation, the PPP, in as much as Alana feels they have not benefited the local person. I maybe to some extent, and I can't blame. The system is still picking up. There's lots to be fixed, but also there are things, for example, that the International Medical Centers under the International Medical Group has done to make sure we have a community social responsibility, CSR, and we give out. If you look at as simple as Mark India, we are looking after cases of HIV free, including clinical care without a coin paid from the guys who can't afford. So that is something that we've taken out. In Sorority, before the lockdown, we planned to do the white stick distribution to people who are blind in Sorority, and that's again another CSR arm that we've taken out and partnering with government. That's on our side, but we want to help the government to help out those people. So I feel we still have done a lot. There are many other CSR activities we've done in Arua, in Gulu, and we will continue to do. I still feel, in spite of the challenges that have been experienced in the PPPs, it's a great opportunity. And Chris, just for you, is that we need to partner and make this work. We need to make this roll out. I don't see why it should not work, especially under the guidance of capable people like you. We can always agree and you see and help us. So I'm not worried at all about the PPP. I think it can be a great opportunity, even in the midst of when the hikes on the charges for telemedicine come in, we can work out something that is easy so that our local communities can still benefit.
Dr. Arthur Sesanga, the Director of Medical Services at IMC, thank you very much. Lana Kembabazi, the Program Manager Right to Health at the Initiative for Social and Economic Rights. Let's talk about the fact that the activation of this tax on data is going to hamper access to technological services or devices that could go a long way in alleviating the physical challenge that we are dealing with right now. Also speak to the fact that maybe government did not learn from the onset of the first pandemic. The fact that we actually did tell them technology would be the only way people might be able to receive these services. But then we have a tax on the internet, meaning on data, in fact, meaning the government did not learn anything from the first COVID-19 lockdown. Didn't we learn anything? And is that where we dropped the ball, Elena?
I actually thought Arthur would be the first one to shout about this tax. I think,
so I had to throw it to you.
All of us, the internet tax, I think it's ridiculous.
Yes.
We say digitalization and we are putting these barriers as well,
yes.
right? And it's easy to think about the internet tax really affecting the rich because you say most of poor, and we argue and we have said that, don't necessarily have mobile phones, but I think we're increasingly seeing that internet is very critical. People trade using, WhatsApp. People share information using WhatsApp. Even before these guys came up with their digital health thing, some people are reaching their doctors through instances like WhatsApp, right? And so I think that the barrier of having a high internet cost has ramifications on how we are operating, on how we are also collecting information. For example, ISA does use some digital tools in terms of our monitoring, and that was very key in our monitoring of violations on the ground during the last pandemic, particularly for health. We did get our community health advocates mobile phones, had loaded on data for them, so they can be able to just monitor who can get healthcare, who can't, what is happening on the ground. Remember, we're all locked down and we could not move, right? So I think that beyond...
Thank you very much, Elena Kembabazi, the Program Manager, Right to Health at the Initiative for Social and Economic Rights. We are running out of time. Chris Locolio, the Direct Digital Country Lead at the UNCD. We would like to know what are some of the strategic bottlenecks that you think we need to overcome if we are to build the capacity of the digital health startups in this country, Uganda. The bottlenecks we have to address.
Indeed. Thank you so much. I think that, of course, as several colleagues have pointed out, there are certain policy bottlenecks that might stand in the way. Many times it's really a balance. You do need to raise revenue to serve your citizens, but of course, those policies should also not be punitive. And so I think that there is a balance that needs to be struck. And so those are certain areas that warrant conversation. I also think that indeed, I think our digital literacy levels are still low. We do not have digital literacy incorporated into mainstream curricula. So people finish their primary education, secondary education, and then say, oh, I'm taking a class in computer, as if it's another level. This should have been mainstreamed all through. So these are some impediments that I think stand in our way. The other is that, as we think about technology, many times people think about, this is for, I didn't really study IT, so I'm not going to venture into that. No, this is now a way of life. And there are several things that have changed for all of us. Unfortunately, there are those in danger of being left behind. And I think that having the right policies in place to encourage uptake and usage is important. I also think that the infrastructure in place is important, that access to networks, to payment service providers, to agents, to the devices that we use. All this is important. And I think we do have to commend initiatives like, now we can get phones assembled locally in order to bring those prices down. These are all initiatives to try and extend that access. So these are some of the impediments. And I think that as we address those, we should get closer to building, because we are in a digital era. And so the digital economy has to be inclusive. And I think that as we tackle those policy, infrastructure, literacy, and innovation gaps, we should be able to get closer to leveraging technology to deliver better healthcare. Thank you so much.
And maybe
Country lead at the United Nations Capital Development Fund. Let's also bring in Dr. Ofi Tamba from the DRC. Dr. Ofi Tamba, share with us some of the recommendations that African countries can employ to be able to ward off or curtail the spread of COVID-19. I'm talking about countries like the DRC, countries like Uganda. What recommendations do you have for us to curtail the spread of the same?
Yeah, I think we should, as DRC and Uganda as country, our government, especially our Ministry of Health, I think should have learned from the first wave that we have. If I have one recommendation is I think that we should think a bit actively about what can happen, like the next step. And I think that we should also, I would recommend the government also to be bold enough to make some big decision about the way our healthcare system is organized. I think that Chris said it earlier. We are in the digital era, and we are not going to be back to the COVID has just showed us that we should move forward, and we think about some component of our healthcare system. And I'm talking about like digitalization. We have started in some area, especially about collecting data in the DRC, for example, for immunization and so on. But I know that it's not enough. We have to rethink proactively about the next step and think also about our reality. We don't want to copy everything for the Western countries, but we have to try to adapt what is currently in place in our country and make sure that we can implement something that is very relevant to our resources. The third thing I can say is also to use the youth for innovative solution. We don't want to see only about, to look at what have been developed elsewhere. We also want to challenge our own youth, people at university, young entrepreneurs, the startups, to develop some tools that we can use in our own context, in our own languages, so that we can address some of the big public health issues such as COVID-19. Thank you
very much, Dr. Ofi Tamba, a public health practitioner from the DRC. Elena Kembabazi, this is a yes or no question because we have largely run out of time. Should we have started the food distribution drive as soon as yesterday, or should we wait for people to die of hunger instead of COVID-19? Elena?
Yes, but they're not going to give food, they're going to give money, which is a fascinating discussion. I think it's better than those who profiteered of giving us substandard food the last time. So I do think for sure we need to have social protection, the modalities of how that money gets distributed and making sure people who are vulnerable are actually excluded.
All right. Thank you very much, Elena Kembabazi, the Program Manager, Right to Health at the Initiative for Social and Economic Rights. We also did have Dr. Arthur Sesanga, the Director of Medical Services at the IMC. Also, Dr. Ofi Tamba, a public health practitioner from the DRC. Thank you very much for having made the time. And finally, Chris Lukolio, the Digital Country Lead at the United Nations Capital Development Fund. The COVID-19 pandemic is still here. Please, strict adherence to the SOPs is the only way we can come out of this debacle. My name is Romy Basiku. Good morning.